Hi, my name is Dr. Kannan Kumar. I'm a consultant hand surgeon in Bangalore, India, and I'm going to be talking about a procedure called elbow arthrolysis. Um, Elbow arthrolysis is done for patients with very stiff elbows. Elbow stiffness is very common after elbow trauma. Any kind of elbow trauma can cause elbow stiffness. This is a 35-year-old male gentleman who's a school teacher by occupation who uses his right hand, whose right hand is dominant, and this injury occurred on his left hand, and he had a capitulum fracture. It looks fairly innocuous on the X-ray, but it can cause severe stiffness and pain to the patient. This is another view of the same fracture. It was attempted to be fixed by another surgeon using a couple of K-wires. These fractures are not easy to fix. They need a little bit of experience and expertise to fix them. So this fracture was attempted to be fixed with a couple of K-wires, and these K-wires were removed after a period of 3 weeks, and mobilization was started. Unfortunately, he did not have great range of motion, nor his pain reduced after the removal of pins and the beginning of physiotherapy. So he met me after a month after the surgery, complaining about lack of motion. The K wires were removed, and this was a picture after the removal of the K wires. There was a large bony block in the anterior aspect, that is in the distal humerus. Also, there was a large bony block from the olecranon, impinging and preventing the elbow from being completely extended. So the block in the anterior aspect, that is in the front of the elbow, prevented complete bending of the elbow or flexion of the elbow, and a block in the posterior aspect or the back side of the elbow prevented complete extension or straightening of the elbow. So then, after about a period of 3 months from surgery, we decided that he was not progressing well enough with this physiotherapy, and we decided to go ahead and do an elbow arthrolysis. That is a removal of all the structures that are causing stiffness. So this is a picture intraoperatively. So he has a range of motion from about 40 degrees of flexion to about 90 degrees. That's about 50 degrees of range of motion. This is just before the surgery. And he was not able to perform many of his activities at this point of time. He was not able to comb his hair, do his regular activities. So therefore we decided to go ahead and do this procedure in him. We did a medial approach, isolated the ulnar nerve, released the capsule, made sure we released all the offending structures, removed the bony blocks, and this is a result we got at the end of the surgery. Complete flexion over 140 degrees and complete extension, or almost complete extension. We could not achieve the last 5 degrees of extension. Um, we put these patients usually on a continuous brachial catheter block in association with our anesthetist. This block is given continuously for a period of 5 days. The first day we do not do any physiotherapy, and the second day we start physio on him, and we keep him in the hospital for 5 days to continue this brachial block. And then after 5 days he has to come daily to the physiotherapist for regular physio, and we hope to achieve at least 95% of the movement that we achieve in drought um, in the post-operative period. And at the end of 4 months after surgery, we usually let these patients off, and the movement they achieve at that point of time stays with them for forever.